Continuing education credits for physicians and other healthcare professionals are provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information. The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed in this podcast are solely of those of the hosts.
Welcome back to the Cribsiders. I'm Chris the Chu Manchu, and I'm joined tonight by my co-host Sam Mazier and our producer, super producer Clara Mao. Say hi, guys.
Hello.
What's up?
Tonight, our guest is Dr. Sonal Shah to discuss vascular abnormalities. But first, Sam, do you want to remind us what this show is all about?
So we are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine.
We had a fantastic conversation with our guest, Dr. Shah, who is the Director of Pediatric Dermatology at Rainbow Babies and Children's Hospital in Cleveland, Ohio. Dr. Shah is also the co-director of the Multidisciplinary Vascular Anomalies Clinic at UH Rainbow, which treats patients of all ages with complex vascular anomalies. In tonight's episode, she teaches us how to classify vascular anomalies, when to have suspicion for underlying syndromes, and what treatment options are available.
Dr. Shah, thank you for coming on our show. Because we're in an informal group, is it okay if we go by your first name?
Yes, please do.
Excellent, excellent. So, this is the first time with us, and, we're blessed to, I believe you're our first up-to-date author on our show, so we're very privileged. Obviously, I don't want to, that's all I'm going to say. I love up-to-date. We all use it. That's all good.
It's a great resource.
Absolutely. So we want to start off by asking a couple questions to get to know you a little better. Could you give us a couple sentences of, who you are and maybe something outside of medicine you like to do?
Sure, of course. So, yeah, I'm a pediatric dermatologist, a vegetarian food enthusiast. I love all things related to design, travel, fashion. I love sweater weather, so I'm in my element right now. Adore traveling and exploring. I'm married to my husband of 15 years, and I'm a mom of 2 girls.
We got to make sure that this one comes out during sweater weather. That's what I was going to say.
Yeah. Oh my gosh.
I think it will be, though. I think it'll be a perfect time when it comes out, and then everybody will be very, very cozy in their wonderful sweaters. That's what we'll say.
This will be our cozy episode.
Yes, this is a cozy episode.
I feel like we need a fireplace and
Exactly.
And this was not one of our planned questions, but since you brought it up, what's your favorite place that you've traveled to before?
Ooh, that's such a good question. I think that the favorite place that I traveled, so in college, I was an anthropology major and I studied abroad in Kenya for a semester. So I was there for more than that time, probably 8 or 9 months. But while we were there, we did a little side trip to South Africa. And I think Cape Town is my most favorite place that I've ever been. It's just a gorgeous landscape. The history is incredible. It's so diverse. It was just amazing.
I have a friend who's living down in South Africa right now, and now I know I need to start cashing in some favors to come for a visit.
Definitely.
Something that we like to ask on this show is, do you have like a favorite failure that you've learned from?
Oh gosh. Yeah. So, I mentioned I'm a mom of 2 girls, and I think since becoming a parent, basically every day is an adventure in parenting failure. There's always situations that you reflect on and you think, oh, I probably could have said that in a different way or handled that better, or maybe that wasn't what they needed exactly in that moment. And so, I think it's very humbling and it makes you reflect a lot. And I always am trying to learn from those experiences. And I think the things that it taught me, or that it continues to teach me on a daily basis, is, it's important to show up. It's important to try to learn from your previous mistakes. It's important to listen to others and just really be intentional in terms of the time that you spend with the people that you love.
I love that.
And then I'll ask the second question. This is very common from our show as well. But we often ask on the opposite side of your favorite failure, what's the best advice you've ever received? Whether that be a learner, a teacher, anywhere in your career, anything to help us and our listeners.
Yeah. So I always share this with the residents that I work with, but one of my mentors in fellowship, who's brilliant, she's an amazing clinician, encyclopedic memory. And in dermatology, it's often the case that you walk in a room and we have just been trained so well in terms of recognizing things on the spot, right? So a lot of times you go into the room and the expectation is you look at it and boom, you know exactly what's going on. And when you don't, it can be a little bit upsetting, right? And a little bit stressful. And I remember that my mentor, who knows everything, she reminded us that, there are going to be times when you walk into the room and you don't know what you're looking at. You don't know what's going on. And the point of residency is not to be 100% in all of these patient encounters and know everything off the bat. But what you are well trained to do is to look at someone and say, I don't know what we're dealing with right now, but I know the steps in which we can take to get us more information to get to that point. And that really changed my perception and approach to patient care. And I think just being honest with patients and saying, I'm not really sure what we're dealing with at this point, but I know that I can do these tests, we can do this type of imaging, and we can start to get some answers for you and head in the right direction. So that really, I thought was a comforting message. And like I said, I always share it with my residents as they're getting closer to finishing their training.
Excellent. That's just fantastic advice. I really love it. And I always love the types of answers we get from our guests from this, because, you would assume that a lot of them would be similar, but I feel like there's always like a nugget like that comes out that's new every single time. So I love your answer, and I really appreciate you being able to answer that.
Yeah, I mean, we've had this theme a little bit with it's okay to say, I don't know. And it's nice to take this to the next point, be like, I don't know. But actually, I can actually go find out, and this is how we can go about doing it. Whether we can find those answers or not, I have a good plan and/or path to get there. And so I think that's the second piece along our large I don't know group. But I always love the I don't know thing, because I don't know a lot of stuff, and that's why you're here. So I'll use that as the segue to take it away. So Claire, if you wouldn't mind starting to read our case, and let's go learn about some stuff. Cold days, big goals, and still no time to cook. This time of year especially, my schedule at the hospital gets hectic, and I don't always have the time to grocery shop or meal prep. That's why Factor has been clutch for me lately. Factor makes healthy eating easy with fully prepared meals designed by dietitians and crafted by chefs, so you can eat well without any of the planning or the cooking. Honestly, my favorite part is that the meals are ready in about 2 minutes. After a long shift, I heat something up faster than I can decide what to watch on TV. It's a real meal, not a snack plate cobbled together from whatever's in the fridge. The ingredients are great too. Lean proteins, colorful veggies, whole food ingredients, and healthy fats with no refined sugars or artificial sweeteners. I've been leaning into their high protein meals, which are perfect for my February routine. They actually keep me full, which makes a huge difference on days when lunch happens at weird hours or not at all. And then there's a ton of variety with over 100 rotating meals each week, so you don't get bored. You can choose from high protein, calorie smart, Mediterranean, ready-to-eat salads, and even their Muscle Pro meals. And support strength and recovery. So everything is always fresh, never frozen, and there's no prep, no stress. It just makes eating well feel realistic, even during a busy stretch at work. And I use this, and you should too. So Cribsiders listeners should head to factormeals.com/Cribsiders50 off and use code Cribsiders50 off to get 50% off and free breakfast for a year. Eat like a pro this month with Factor. New subscribers only, varies by plan, 1 free breakfast item per box for 1 year while subscription is in. We've all been there. You walk out of a patient's room and need a focused differential and management plan now. Sanford Guide, known around the world for its much-loved antimicrobial therapy guidance, has covered you with a new app for pediatric acute care. There's no need to find an empty workstation. On your phone, you can search over 500 pediatric acute care topics in seconds. What you get isn't bulk or filler, it's streamlined, clinically nuanced guidance that's continuously updated by experts from the leading children's hospitals. This isn't an encyclopedic reference to scroll endlessly, and it's not an AI-generated summary. Every topic is intentionally written in a succinct, high-yield format from the start. So the Sanford Guide to Pediatric Acute Care app gives you exactly what you need at the bedside. Clear diagnostic reasoning paired with practical, evidence-informed therapeutic guidance. Search for Sanford Guide in the app stores, and Cribsiders listeners can get 20% off the already very moderately priced yearly subscription directly from sanfordguide.com. Go to sanfordguide.com and use the code Cribsiders at checkout.
So our first case is Rosie. She's a healthy 2-month-old here for her routine well-child check. Her parents ask you about a new mark on her right cheek that they first noticed a couple weeks ago. The lesion is bright red, it's slightly raised, and it's about 1 centimeter in diameter. It's grown since it first appeared, but it doesn't really seem to bother Rosie. So to start from the basics, what is the difference between like a vascular tumor and a vascular malformation, and what's your differential diagnosis like hearing about this case?
Yeah, great question. So when we think about vascular anomalies, we divide them up into 2 broad categories. So the first is vascular malformations, and then the second is vascular tumors. Vascular malformations, they are congenital, non-neoplastic abnormalities of vasculature. And they can affect any part of the vascular system, but mostly it's characterized by an overabundance of specific types of vessels. Sometimes they're simple, meaning it's just one type of vessel that can be involved, like a capillary malformation or a venous malformation. And sometimes they can be what we call combined malformations, where there's multiple types of vessels that are involved. And then the second thing that we think about with vascular malformations is we think about what's the flow level within them? Are these vessels that have a lot of high flow associated with them, meaning lots of arteries within them, or are they more low flow? And then with vascular malformations, again, we also think of them as being isolated. Is this just a finding that we're seeing in the skin, or is it part of a broader, more syndromic condition that we have to worry about? And then the second big category in vascular anomalies are vascular tumors. And these are neoplastic, which means there's increased rates of proliferation of endothelial cells and vascular cells within them. And neoplastic can be referring to benign neoplasms, and oftentimes we categorize things based on their aggressive qualities. So is it benign? Could it be borderline or locally aggressive? And then there are some that are malignant as well. A lot of times these vascular tumors can be congenital, but they can also be acquired. And many of them have the capacity to self-regress. So that's kind of the main distinction between vascular malformations versus tumors. And then I think the second part of your question was, what are we thinking is going on with Rosie and the spot on her cheek, right? So I would say just based on the history that was provided in terms of her age, when it showed up, the description that you gave, probably the highest thing on my differential would be a infantile hemangioma. Of course, I'm a dermatologist, so I want to see it in real life to really be able to, pick up on certain qualities that can be clues on the skin. But that would be my leading diagnosis, just based on common things being common.
And is the infantile hemangioma a group of a vascular tumor or a vascular malformation?
So it's a tumor because, again, it can rapidly grow, whereas malformations are typically not going to.
Awesome. So when you see this patient, right, how do you make the diagnosis of infantile hemangioma? You're walking in, you heard the history, right? Say it's a medical student or resident came out and presented it to you, and so this is what you heard. How are you going to make that diagnosis?
Yeah, I think, like I talked about before, dermatology is very visual. So when we look at hemangiomas, I usually can tell there's a very specific color to a hemangioma, particularly ones that have a superficial component. It's just super characteristic. There's nothing else that has that type of color to it. In dermatology, we always try to get away from erythema and stuff like that. It's just a non-specific term. So we really like to ascribe, qualities to that particular red. And so that's one of the big giveaways is just the appearance of it, the color of it. There's nothing else that's really hemangioma red in the skin.
And if there was something to be, what would our differential diagnosis be? Is there anything that we should think of as our second and third? And it could be very far off on second and third. I just want to know, like, because if I go in and I see, and if I'm the primary care doctor and I see that color, I'm like, boom. Or should I be like, all right, I think boom, or is it two other things? And you can easily say, guys, there's nothing else there.
No. I mean, of course, there's always a differential, right? And there are certain things that can certainly mimic infantile hemangiomas for sure. If it was a little bit smaller, you could think about a pyogenic granuloma, which is kind of an acquired proliferative vascular papular nodule that you can see. Obviously, you can always think of really aggressive vascular tumors that can just start to grow. Many times the color is a little bit different. And then there's a whole bunch of other non-vascular things that can be mimickers of hemangiomas, like myofibromas and things like that. So there is obviously a broad differential. And in some instances, if there's something a little bit off about the appearance, we start to go down that track. But I would say many times hemangiomas, infantile hemangiomas, can be pretty distinctive in terms of their appearance. So you can be pretty confident in making that diagnosis in the right clinical scenario.
And is an infantile hemangioma the same thing as a congenital hemangioma, or are those different things?
They are different, and the terminology is so confusing. So I'm glad you brought that up. So congenital hemangiomas are a totally different thing than infantile hemangiomas. Congenital hemangiomas actually develop in utero, and they are fully formed at birth. And that is contrasting to infantile hemangiomas, which oftentimes are not present immediately at birth, or if there is, there might be a small precursor lesion, but then they had a very significant post-birth proliferative period of time. So their natural history is a little bit different. Congenital hemangiomas can behave differently as well. They can spontaneously regress. Some of them partially regress. Some of them don't regress at all. So their clinical behavior is a little bit different. We know that congenital hemangiomas are by and large due to somatic mutations in certain genes like GNAQ or GNA11, whereas infantile hemangiomas don't have that particular genetic change associated with them. So they're very different in terms of how they behave. How they look actually can be very different as well, and their underlying pathogenesis is different as well.
And, while we're kind of on the topic of diagnosing these vascular anomalies, I think we've talked a lot of, in dermatology with skin of color, we know there are racial disparities at times with like diagnosis and management of different conditions. Do you mind elaborating on that a little more?
Yeah, sure. So I think that definitely we know that racial disparities can affect our ability to diagnose and manage vascular lesions. And a lot of the data that we have comes from research specifically related to infantile hemangiomas. So one of the things that I think is playing into this is that infantile hemangiomas are actually not that common in darker skinned individuals. So if you look at various studies that are out there, looking at large population studies of infants with hemangiomas, probably between 4 to 8% of those babies will be Black. So we don't see hemangiomas that often in darker skin. And then the second thing is that in darker skin, as you have more and more melanin, vascular hues that you can oftentimes see that are in lighter skin, more red or blue or purple, can take on a more hyperpigmented look about it. So that typical color that I was talking about with hemangiomas might look more maroon instead of that bright red that you're used to seeing. So we don't see them that often in Black skin, and then they can look different. And so I think that can lead to significant delays in diagnosis. And there have actually been studies that have looked at race and time to diagnosis, time to presentation. And we definitely can see a significant delay in terms of infants that are Black in presenting much later to subspecialty care for their hemangiomas. The other thing that we actually also see is we did this big study that looked at ulcerated hemangiomas in infants. And what we found was that similarly in that study, infants that were Black presented to their pediatric dermatologist or subspecialist a full 6 weeks later than their white counterparts. And they were almost 2.5 times more likely to develop ulceration, which is the most common complication compared to white infants as well. So that also speaks to a little bit about perhaps, again, delays in diagnosis, difficulty accessing specialty care, as well as poorer outcomes as well. And it's not just race, to be honest with you. We also know from other studies that patients with low socioeconomic status across the board, regardless of race or ethnicity, are also more likely to experience delayed access to care for their hemangiomas. So these are all things that we definitely know from the literature. And I think part of the reasons are, again, difficulty or delays in diagnosis for the reasons that we talked about. And again, it's very hard to access subspecialty care.
Now, you said a couple times as we're talking about this case and sort of how you overall look at these patients that, some hemangiomas have a very specific look, and then obviously they may look a little different in different individuals of different, varying complexition. Do you have any good? I know we have we're an audio podcast, and I can see some folks in the cars how do I do this? Do you obviously we'll try to put these in our show notes, but do you have any recommended resources for people to be able to reference and look at different types of hemangiomas, especially ones that may have a variety of samples that may be coming from people with different complexions, and hopefully free, that they can get a hold of? And if not, what are your favorite atlases and resources?
Yeah. So one of the ones that a lot of institutions will have a subscription to is something called Visual DX. I don't know if you've ever heard of it before, but Visual DX is basically an online collection of photographs. And they have done a very good job of curating images in people with different skin tones. You can actually search on Visual DX. You can put in different parameters and you can check skin of color only, or you can separate it out by, age group or whatnot. So that, I think, is a very good resource if you have institutional access. If you don't, you should ask your institution to get it, because it's really, really helpful. Even in our clinic, we have it up all the time, and we're constantly kind of referencing things. So I think that is that is definitely a great resource. There are a ton of great atlases that are out there, and I can certainly give you guys names and whatnot. There's some great pediatric dermatology textbooks that we always refer to, like Hurwitz or Neonatal Derm, that have really good photos as well. The American Academy of Dermatology is kind of an online image bank that people can flip through as well. So those are the resources that are available. There is another one online that is free. It's not as great in terms of being able to access a wide range or diversity of photos, but it's called DermNet NZ. It's from New Zealand, but that's free for everyone and accessible on the internet.
Yeah, I have a Visual DX subscription that I look at, but I think that the DermNet New Zealand, I feel like, showed up in a lot of my lectures in medical school.
Yeah. And I mean, I always say, Google is helpful, but you never know what you're going to get, right? So you could Google one thing and they could be showing you pictures of something totally different. So just be careful with the run-of-the-mill Google search.
Awesome. So you mentioned, for example, as one of the complications, ulcerations, and how late presentation can lead to that. Can we talk a little bit about the natural history of infantile hemangiomas? What are our concerns? Why do we care, for example? And then you can kind of walk us through how you also explain it to families kind of at the same time. Treat us just like them.
Yeah. So I see a ton of hemangiomas in my clinic, so this conversation comes up multiple times per day. But I always take families through, again, what we expect to see, right? And so we talk about how hemangiomas are blood vessel growths that are benign. And I refer to them as birthmarks, although I do make the caveat that oftentimes they're not there at birth, but they do tend to show up over the first few days to weeks of life, after which they can grow pretty rapidly. And a bulk of hemangioma growth happens very, very early on. Probably 80% of hemangioma growth happens between months 1 to 3 of life. And that's important as clinicians, because there is a very significant window of opportunity that we have where we can intervene with therapy if required, where we are more likely to have better outcomes. So if you are a general pediatrician and you're seeing an infant at 4 weeks of life at their well child check and they have a hemangioma and you're a little bit worried about it, that is the appropriate window for referral and for them to be seen by a hemangioma specialist to really make that determination of whether treatment needs to be implemented or not. So that early proliferative phase is when we want to intervene and kind of think about whether or not treatment is indicated. But even after that, there's sort of this late proliferative phase that can last until months, maybe 6 or 7 of life, where you can still see continued growth, but it's not as rapid as those early months. After that, the hemangioma stabilizes, and we call that the plateau phase, where you're not seeing too much change happen. And then what you will start to see very gradually is what we refer to as involution. And this is where the hemangioma starts to regress, starts to shrink up a little bit. Those blood vessels that were laid down initially are replaced with fibrous tissue, fatty tissue. And that involution period is very slow. It can take several years, usually until around year 5 of life, for that to be complete. And the other point that I always like to make to families is that involution does not mean complete resolution. And I think even within medicine, this was a very common misconception. And I still hear it from time to time where people say, oh, I was just told it would go away, right? So yes, it will improve. Yes, it will involute and regress, but that doesn't mean that there's not going to be anything left behind. And we do know that a high percentage of hemangiomas can have significant sequelae, whether it's residual telangiectasias or textural change or a fibrofatty lump that's in place. That's not necessarily desirable, right? So those are the things that we are thinking about when we are looking at patients and looking at their hemangiomas and deciding whether or not we want to think about therapy. All of those things kind of come into play.
One practical question about that referral that you're talking about. So we see the infant, probably around, 4 weeks of life because, everything is going on. And at that point, that's probably when these hemangiomas might be even the most noticeable. And we place that referral for pediatric dermatologist. And so that proliferation phase is like 1 to 3 months, right? So if we place that referral, would a pediatric dermatologist be like, oh, yeah, this is a referral for this type of thing. I really should try to get them in these next 1 to 2 months so that we can discuss and have management. Or is this something that, hey, we have to be this is not like a stat referral, but we need to have this baby seen in the next 1 to 2 months.
Yeah. I think a little bit of both. I think the tricky thing with referrals, at least in our system, you put in the referral and it goes to some outer space. I don't know what happens to that and who lays eyes on it. But it might not necessarily be my staff, right? That knows that, yes, we have specific guidelines for when we want to see hemangiomas, right? So I would say that within my community, I have made it very well known that I want pediatricians to reach out to me and just send me a message and say, hey, I have a baby with a hemangioma. I put in a referral. Photos are in the chart. Take a look, and can you get them in? And really within my practice, I will see them within the week. I will overbook them. And I think any pediatric dermatologist, because we understand that this is a time-sensitive condition. And if it goes untreated for a while, you're at a point where then even if you initiate therapy, you might not get as great of results as you would have wanted if you had started it within that optimal window. So any pediatric dermatologist would be happy to get a message or a phone call to say, hey, I put in a referral. I'm not sure. What do you think? And then it's kind of up to them to figure out what's the appropriate time frame.
And we were talking about the natural history a little bit, and you talked about involution does not mean resolution, and that can lead to what seems to be certainly cosmetic changes later in life. How destructive can these be as well? I could say, hey, extra telangiectasia is maybe not that big of a deal. Obviously, we have treatment so we can prevent that, but not the worst thing that happened. But if this ate through someone's nose, I would say that'd be a problem. So how destructive can these be?
They can be pretty destructive. There's a certain subtype that can be quite aggressive. And you're right, we can see it, causing destruction of cartilage that can lead to significant deformity. I've seen it cut through an entire lip and create an ulceration that almost looks like a cleft lip. I've seen nasal cartilage completely obliterated by these. So in large ones, you can see very significant ulceration that is affecting, 80, 90% of the entire hemangioma. So these can be pretty destructive. I think certain areas are at higher risk for that than others. And, certain types of hemangiomas in terms of how they're distributed on the body and their size can kind of put you at a higher risk for sure. But I've seen some unfortunate complications as a result.
And, while we're talking about some of these higher risk infantile hemangiomas, can you touch on what are the red flags of an infantile hemangioma that would make us think there might be something syndromic going on and we need to do further testing, imaging, et cetera?
Yeah. So I think that there are a few distinct clinical scenarios where you might want to think about additional workup or doing some imaging. So the first is in an infant that has multiple cutaneous hemangiomas, and usually the cutoff is 5 or more. In that instance, the second most common place for hemangiomas to be is within the liver. And so that would be a tip off to say maybe we should do some ultrasound imaging of the liver to see, because liver hemangiomatosis, if significant, can cause some pretty significant issues like liver failure. It can cause hypothyroidism. It can cause congestive heart failure. There's a lot of complications that can occur as a result. So multiple cutaneous hemangiomas would prompt you to think about looking at the liver. If you have a hemangioma that is segmental in distribution, meaning it's covering a very broad territory along the jawline, lower lip, or anterior neck, that's another scenario where you might want to think about where else could the hemangioma be. And one of the places that we can see hemangiomas in that particular distribution is within the airway. So obviously that can be life-threatening if you have a hemangioma that's rapidly growing within the airway. So that might prompt you to do a scope and evaluate and see what's going on. And then there's two kind of more conditions or hemangioma scenarios where we might think about underlying structural anomalies. And the first is with a large facial segmental hemangioma or a large scalp segmental hemangioma. And when I say segmental, again, I don't refer to those tiny ones that are circles that look like they just arise from one little focal point. These are really large hemangiomas that look like they are covering a broad territory. And there's a really nice reference that I can give you that you can put in the footnotes that sort of outlines the facial segments that are known and that are well mapped. That might tip you off to whether or not you should be thinking about a condition called face syndrome, which is where you have a constellation of symptoms that include posterior fossa abnormalities, large facial or scalp segmental hemangiomas, arterial anomalies, coarctation of the aorta, and eye abnormalities. So in that instance, you may want to do some imaging. You might want to get an echo to look for any coarctation of the aorta. You might want to do an MRI, MRA, looking at the vasculature within the neck, within the brain, that kind of thing, to look for any of those arterial anomalies. And then the counterpart to that is a lower body hemangioma, a lower body segmental hemangioma. And that can be seen with a condition that we call lumbar syndrome, where you can get urogenital anomalies, you can get bony anomalies, myelopathy, arterial anomalies, and renal anomalies as well. So if you're seeing broad segmental hemangiomas on the face, on the scalp, or on the lower body, pelvic, lumbosacral area, those are scenarios where you may want to do a little bit of an investigation.
Awesome. I think it's time to start talking about treatment, because we've talked a lot about, okay, these are the things to look for. I think let's start with how you would recommend treatment, and then we'll kind of talk about indications, because I think that will come through as you talk about this. So if you wouldn't mind taking us through the, I guess we'll call it first line or gold standard of treatment for hemangioma.
Yeah, so probably for the last 15 years or so, really our gold standard of treatment for hemangiomas that require therapy are beta blockers, whether that is systemic with propranolol or other systemic beta blockers, or topical with timolol. And for me, I tend to use a lot more propranolol than I would timolol because I think that there's a very small subset of hemangiomas that would actually respond well to timolol. So I will consider timolol in a hemangioma that's pretty small, superficial, meaning it has most of its component on top of the skin as opposed to in the subcutaneous tissue, and ones that are overall pretty flat. If a hemangioma is starting to get quite raised, that's really not a hemangioma that's going to respond well to timolol. So I have a very kind of narrow criteria for which hemangiomas I think might respond well to timolol. But if you do have a small one that's pretty flat, you're catching it early, timolol can be great, and it can kind of really hold things at bay and prevent that significant growth and elevation that can happen. But like I said, if it's starting to get thick, if it's starting to get elevated, if I'm really worried about it impacting any type of function, then I might really think about systemic therapy with propranolol.
And just to complete the timolol, it sounds like propranolol is where it's at, and you have to have a reason to go timolol rather than the other way around. But timolol sounds very low risk as a medicine. How does one prescribe it? So say I was a primary care doctor, what am I actually writing for?
Yeah. So usually what I write for is timolol 0.5%. It can come as a solution. I personally like the gel forming solution, so it kind of thickens up a little bit and stays in place. And we just have patients use it 1 drop over the area of the hemangioma twice a day. And we really do try to limit it to 1 drop twice a day. So we can't be using it on a very, very large surface area because we do know from pharmacokinetic studies that you can actually get systemic absorption with timolol into the bloodstream. So we really do try to limit it to 1 drop twice per day.
And kind of backing up even further, how do you decide which infantile hemangiomas to treat? Is it kind of like cosmetic? You talk to families and have that shared decision making, or do you just go ahead and treat most of the ones that you see?
Yeah, so I think the ones that I definitely consider treating are any of those that are at risk for causing any type of functional impairment. So say you have a large bulky hemangioma over the eyelid, and it's causing ptosis. That's an example of functional impairment. So that's a no-brainer. Those are ones that we're going to treat. We always treat hemangiomas that we're worried about disfigurement. So obviously we think about disfigurement with hemangiomas that are in locations like central face, very, very visible. But I would also say that our definition of disfigurement has expanded pretty significantly with the arrival of propranolol onto the scene because it's such an effective medication that we're actually treating so many more than what we did before we had propranolol, and also because it's really well tolerated as well, and the side effect profile is pretty favorable. So the goalpost has moved a little bit in terms of what do we consider to be disfiguring. In the past, maybe we wouldn't have treated a hemangioma on the scalp that could leave behind significant alopecia, but now I'm more likely to treat that because who wants to have an alopecia patch on their scalp when they're a 14-year-old, right? Same thing with, a larger hemangioma on the trunk. Yeah, it's not a visibly notable area. Most of the time it's going to be covered, but would you really want a large residual fibrofatty lump there when you're older? Is that something that, eventually, if it's big enough, you'd want to have surgically removed? Can we save you from having removal or revision of that excess fibrofatty tissue down the line? So those are all considerations that we take into account. Of course, there are some very clear-cut ones where we're like, we have to treat, and this is what we're doing. And then there are other ones where it does become a discussion with the family in terms of risks of treating and risks of not treating. And so we make those decisions together after, families have all the information of what their options are.
So Cribsiders listeners, let's talk about something that actually changed my day-to-day life as a hospitalist. FIGS. I can't walk into a clinic or hospital without seeing people in FIGS scrubs. And I get it, I wear them too. So, new year, new you, or at least new uniform. If you're in healthcare, it's the perfect time to upgrade your scrubs to FIGS. They're lightweight, durable, super functional, and ridiculously soft. These scrubs get it. That's what drew me in and keeps me coming back. And because we work with kids, and kids come with messes, I love that figs are antimicrobial, can withstand wash after wash and come out wrinkle-free. I've washed mine over 50 times and they still look brand new. So with new limited edition colors and styles, Figs is putting the fresh in uniform refresh. Scrubs, outerwear, footwear, accessories, and more. You'll be looking sharp, feeling good, and ready to take on anything. 2026 is here, so let's do this. And Cribsiders listeners, you can take 15% off your first order at wearfigs.com with the code FIGSRX. That's wearfigs.com, code FIGSRX.
So with something that, say the lesion's fairly small and, I feel pretty comfortable as a pediatrician to, at least while we're waiting to get into the dermatologist, and I feel comfortable prescribing topical timolol, is there anything specifically wrong if I'm pretty sure of the diagnosis based on the way it looks? I've seen enough hemangiomas that I'm like, you know what, parents like, ooh, we're not sure what to do. It's going to take us another, they got a schedule, but it'll be in a month. Would there necessarily be anything wrong with me saying, hey, let's try some topical timolol in the meantime? Or is that something maybe we should wait?
No, I think that's reasonable. Again, especially if it's one of those ones where you have a high index of suspicion that it might be effective for, right? If they have a big bulky hemangioma, that's probably not the one you're going to want to prescribe timolol for. But yeah, we have a lot of pediatricians in our network that do feel comfortable, and it's very helpful because they may be doing something to blunt that growth, right? While they're waiting to get in to see dermatology. Timolol overall, again, if you're sticking to those parameters of 1 drop twice per day, pretty safe. It's really well tolerated. So yeah, it's a good tool to have in your back pocket for those lesions where you're confident it is a hemangioma and ones that are small and superficial.
Awesome. So let's talk about propranolol. So propranolol sounds like I should just prescribe propranolol right now. But how do I do it? What do I need to worry about? Can you take us through kind of your initiation process for these patients and families?
Yeah, so for most infants, we're able to initiate propranolol as an outpatient, so they can do it at home, particularly if they are greater than 5 weeks corrected gestational age, and they have no other conditions that might be contraindicated to starting propranolol, so no cardiac issues or anything like that. So, when we're thinking about starting propranolol as an outpatient, the most important thing is obviously you're taking a thorough history, not just for the skin, but for everything else. So we always ask about, are there any cardiac issues, any pulmonary issues that you know about? We listen to the heart, we listen to the lungs. We always read through the pediatrician's note to make sure they haven't picked up on something that we might have missed. And if the baby's otherwise healthy, then we can go ahead and start. And so usually with propranolol, the side effects that I typically like to counsel families on are, I kind of divide them into 3 categories. So the first are common side effects that we see, and those include things like cold hands and cold feet. Some babies will have looser stools when they first start on the medication, sleep disruption, fussiness. Those are things that we can see a little bit more often. And then, I always talk a little bit about potential risk, more of like a theoretical risk of the medication causing bradycardia or hypotension, which certainly in very, very high doses that could be there. But there's been pretty extensive studies that have looked at vital sign monitoring in infants initiating propranolol. And really, there hasn't been any significant changes that have any type of physiologic impact with regards to heart rate and blood pressure. So I tell people about it because people might want to read up on it and they might see it on a Google list if it pops up, but kind of explain the reasons why we don't really think that is something that is likely. And then the last group of side effects are more rare, but they are the ones that are more significant that we worry about. And the main one is hypoglycemia. And we know that propranolol, we're not exactly sure what the mechanism for causing hypoglycemia is. We know that propranolol may blunt some of the physiologic effects that you might see as a result of hypoglycemia, so it might be harder to detect. And the way that we go about preventing hypoglycemia is really by making sure the medication is given with feeds with or following feeds, and that the infant is feeding at pretty regular intervals throughout the day, and in some instances overnight as well. So usually when you're starting an infant when they're pretty young, they're eating every 2 to 3 hours around the clock. And so it's not too much of an issue. Where it becomes a little bit more of an issue is when you have older infants, their feeding schedules kind of changing a little bit. They might be wanting to go longer stretches overnight. And that's where we can sometimes get into a little bit of trouble. So I always tell family, make sure you're giving it with food, feeding at frequent intervals. If they're not eating well for whatever reason, I always just tell them hold off on those doses, wait until their appetite is kind of back to normal just to be safe, and then resume.
So what are some of the doses for propranolol do you start, and then how would you titrate that?
Yeah, so usually I would say a good goal dose for most hemangiomas is around 2 milligrams per kilogram per day. And typically that's divided in twice daily dosing. And so when I do, and everyone does this a little bit differently, but when I do outpatient initiation of propranolol, I will up titrate over usually a 10-day period of time where I'll have them do half a mg per kg divided BID for the first couple days, then go up to 1 mg per kg per day for divided BID for the next couple days, so on until they get to 2 mg per kg divided BID. In which case, then I have them remain on that until they come back and see me. Sometimes for really young infants that come in that are not 5 weeks corrected, I will initiate propranolol in the office, and those are lengthy visits because we keep them there for a while. We're monitoring their vital signs just to kind of be sure. But most of the time we can do it as an outpatient now.
And how do you decide if you need to increase the dose? Like, are you like, I don't know, like you take lots of pictures of the hemangioma, you're comparing them, like that appreciably look smaller, or do you like do some sort of measurement? Like how does one look at that and see if they're responding like you want them to?
I photograph everything because it's impossible to remember what things looked like. I usually don't do serial measurements. It's really just based on how does it look? What's the color look like? Is it less full than before? What's the texture? Is it a little bit softer and squishier as opposed to really firm? So those are the things that I'm kind of looking at. But yeah, we photograph everything in our clinic, which is great. But those are the things that we look at. And, there are some instances where, you're not getting as much benefit as you would have hoped. And most of the time in these scenarios where I would consider pushing the dose, it's a rather large hemangioma or one that's particularly, trying to be aggressive. And those are the ones where I might consider increasing the dose even beyond that standard of 2 mg per kg per day, usually up until around 3 milligrams per kilogram per day. I don't usually go past that.
And then for monitoring those side effects, we'll take any of the infants that are over 45 weeks gestation that you would do in the outpatient setting. Do you do any monitoring for them at home, for example, or have any vital sign measurements, any glucometers in their world, anything along those lines? Or we feel pretty confident about that, all the things based on just their clinical syndrome, and the parents can obviously bring their child in if something doesn't look right.
Yeah, there's usually no home monitoring that's involved or, random glucose checks or anything like that. We kind of tell the families what to look out for. And in those low risk infants, we really don't do any significant type of monitoring.
Do you ever get any like good side effects that parents randomly complain about? Like, oh, our baby's usually colicky, but as soon as we start the propranolol, they're like chill as all get out. I don't know. No.
That's interesting. The one scenario I had a baby that family was just really worried. They were super constipated. And then when they started the propranolol, their stool got a little bit looser. So they were happy about that. That was just one family though. Most of the time when the stools get loose, the families, they don't love it that much, but
I understand that.
And I guess one more question about this is kind of brings up is it working? Does it not? That's Chris kind of said earlier, but how long are you expecting to treat at 2 mg per kg per day? When would you expect this to be done? When would you expect the treatment to end? And when would you expect to say, it's not going the way I want it to, we need to change our tactic?
Yeah, so I usually keep infants on propranolol until around their first birthday. And I tell families that up front. That's kind of the expected course. And that's really to get maximum effect of the medication. Obviously, you want to have it on board the entire time the hemangioma has growth potential. But we also know from studies that there is a risk of what we call rebound growth, which is when you stop propranolol for certain hemangiomas, they can regrow. And we know that if we stop before a year of life, those particular hemangiomas are more likely to regrow. And if we go through that first birthday, less likely. So that's usually what I tell families. And then again, for those larger hemangiomas where, it's a little bit more critical or in more significant locations where we're worried about it, I see them back, within a month, every couple months. And if we're getting the sense that nothing is really changing or it's continuing to grow despite propranolol, which I have seen on occasion, that's when we might start to think about changing gears, whether that's switching to a different type of beta blocker, whether that is switching to the branded formulation of propranolol versus considering other modalities like systemic steroids or in some instances intralesional steroids or whatnot. We kind of make those decisions as we need to when we see them in follow-up.
So you do get patients that respond to the branded version of propranolol versus just the generic?
Yeah, rarely, but yeah, sometimes.
And before we go on to the to kind of those other modalities, if we want to talk about them, if you're doing the whole year, how often are you weight adjusting these doses for them? Are you bringing them every clinic time they see them, or the pediatrician doing it, or are you just letting that dose run out when they're 1?
Yeah, I usually, so like I said, once they're established on their propranolol, I'll see them back 1 month after initiation. And then usually after that, if they're doing pretty well, every 2 months. And I'll weight adjust at every visit just to keep them kind of on the most optimal dose.
And then when you do stop at a year, are you like stopping them cold turkey, or are you a slow wean over time? And then what's the follow-up look like to make sure we don't have this rebound issue?
Yeah. So I think everyone who treats hemangiomas might do this a little bit differently. There's not really a standard in terms of how to stop. I do usually do a very small taper. I'll have them, if they're doing twice a day dosing, I'll have them drop it down to once a day for a week or for 2 weeks, and then I'll have them stop. And I let families know what to look out for rebound growth, particularly for those ones that I think have a higher risk of having rebound growth. Which, might be variable person to person. It could just be a little bit of increase in color. It could be maybe a little bit of increase in fullness. It could regrow to the size that it was before you started propranolol. And I always tell families, if you're noticing any of those things, just snap a picture, send me a MyChart message, let me know, and we can compare and see how things are. And if we feel like we're okay to just kind of watch things because maybe the degree of rebound growth isn't as significant, then we can do that. Or if we feel like maybe we need to consider another round of propranolol, we can kind of do that as well. So I don't typically, when I stop propranolol, I personally don't necessarily see every single person back in follow-up just to see how they're doing, but I always leave the door open for the families to reach out to me if they're noticing anything on their end, and to bring it to my attention.
Awesome. I feel like we've gotten like a really deep understanding of like infantile hemangiomas now and like how to actually talk to parents about treatments. Before we move on to our next case, anything else that you want to talk about within this topic?
No, I think just the main things are really from the perspective of a pediatrician, knowing which hemangiomas are kind of higher risk, meaning that they may be good candidates for treatment. So being able to triage which hemangiomas might require referral. And then also really drilling down on the timing of referral. And early referral is really going to be most beneficial for parents and for the patient to get optimal outcomes if we do decide to start treatment.
Awesome. Well, then I'm going to take us into our second case,
Okay.
which is going to be a newborn who has a large, well-demarcated pink patch involving the right forehead and upper eyelid that was present at birth. And his parents are seeing you in office and they want to know if they should be worried about this and what this could be.
Yeah. So, from what you're describing, a flat pink patch over the forehead, over the eyelid area, it sounds like it could be consistent with what we call a capillary malformation. So, again, capillary malformations are a type of vascular malformation due to a collection of extra capillaries near the surface of the skin. Other names that you may have heard it referred to by would include things like port wine stain, or now we say port wine birthmark, et cetera. So those are in some ways interchangeable. And these capillary malformations can be located anywhere on the body. But when we see them in certain locations, we do start to wonder if there could be any underlying other conditions that could be associated with it. And definitely when we see a capillary malformation that involves the forehead, any part of the forehead, but also kind of involves the upper eyelid, we do think about a condition that we can see from time to time called Sturge-Weber syndrome, which is a neurocutaneous disorder where you can have the capillary malformation of the face, but you can also have issues like glaucoma, seizure disorder, leptomeningeal angiomatosis, that kind of thing, and some pretty significant developmental delay in certain instances. So capillary malformations, like I said, located in certain parts of the body, we do start to worry about associations, but there are some capillary malformations that can be isolated, just located on the flank or on a part of the arm. And in those scenarios, we might not necessarily be worried about anything underlying.
And so how would you say these types of malformations, are they different from, say, like a stork bite or angel kiss malformations? I always feel I get these things mixed up because they're always sort of like these reddish things that happen.
Yeah. So technically a stork bite, so our name for it would be nevus simplex, but people will say angel kiss, stork bite, that kind of thing. So they are actually a type of capillary malformation, and they tend to show up in very specific locations, and they tend to have a specific look about it. So they tend to be more kind of like pinky or sometimes salmony in color, and very, very common places for it to be are located between the brow, on the glabella, a little bit maybe on the forehead, upper eyelids, very common. Occipital scalp is another common place for it to be. We can also see it in some instances like on the philtrum, upper back, lower back. The borders tend to be very feathery. It's a little bit more patchy, so it has a little bit of a different look about it. And when you see it on the upper eyelids, it oftentimes tends to be symmetric, so that's another clue to it. But those typically tend to fade over time, apart from the ones on the occipital scalp. But the ones on the face, on the eyelids, those usually tend to fade over the first couple years or so and are definitely not associated with anything worrisome.
And for the capillary malformations, we'll exclude the nevus simplex for now. But the other group of capillary malformations, we talked about the vascular tumors or the hemangiomas, the benign ones, doing more of the involuting piece. Is the natural history similar for these capillary malformations? Will they go down, or are these going to look the same way unless we do something for treatment?
So capillary malformations are so heterogeneous. There are so many different ways in which capillary malformations can present on the skin. Sometimes we see them as like a very dark purpley color. Sometimes it's more of like a homogeneous maroon color. Sometimes they can be very patchy, or what we call reticulated, where they have a lacy type of look about it, and they can be very, very dull pink. So all of those different types of capillary malformations can behave differently. Sometimes we see those very, very faint ones that are a little bit more reticulated. They become less and less noticeable over time. And then sometimes we see ones that are more homogeneous or have that really, really deep color. Sometimes we can see them becoming hypertrophied over time, where you can get cobblestoning of the skin. Sometimes you can get associated soft tissue overgrowth. So not all capillary malformations are the same. And this is one of the things that is so cool about pediatric dermatology in the world of vascular anomalies, is that we are really now able to better characterize these, right? And being able to better characterize these things and knowing a little bit more about the genetic basis underlying some of these, we can really give our patients a better understanding of what they could potentially expect in the future. So we're able to counsel a little bit better, just being more observant and putting together the pieces of, oh, these behave in this way and these are more likely to do this.
Maybe I'll flip this around and say this. Which capillary malformations would you recommend we refer to pediatric dermatology?
Ooh, good question. Certainly not nevus simplex unless the diagnosis is in question. I think any other capillary malformation I think is fair game, because there may be some subtle changes that we might know to kind of look out for that might make us think that, is this something that's more syndromic, and are there other things that we need to think about by looking at the toes, for instance, by looking for subtle overgrowth or undergrowth of the affected areas, by looking for things like macrocephaly, taking into account any developmental delays. Those are all clues and things that can be kind of subtle that might make us think that there's something underlying or syndromic that we need to kind of address. So I think any other capillary malformation is fair game. And I think any pediatric dermatologist would be excited to see a patient with a capillary malformation.
And then maybe I'll just ask the last follow-up question to that. So the additional workups for associated syndromes are often the thing we're thinking about. Is there any one that you want to just give us? Is there any super high buzzword that you want to give us for the ones that we should not miss?
Yeah, so I think the main one is Sturge-Weber that we talked about, right? And so the main things that if you are seeing a forehead capillary malformation, if there is any involvement of any part of the eyelid, definitely want to get ophthalmology involved to get a good eye examination, to look for choroidal angiomas, to look for glaucoma. So they need to be a part of the treatment team. Oftentimes, we are considering MRIs of the brain as well to look for any telltale signs of leptomeningeal angiomatosis. Sometimes you can see calcifications in a certain part of the brain. And in those instances where we see those changes, we want to get neurology on board because seizures are a very prominent feature of this particular condition. So that is certainly a scenario where you would want to either consider referring for further workup or potentially initiate that workup yourself.
And when we, send patients and they're seeing you in clinic, what kinds of treatment options are available? What do you talk to families about?
Yeah, so for capillary malformations that are, located in prominent locations and whatnot, we can use certain types of lasers that can target vascular structures underneath the skin to help improve and fade the clinical appearance of that. So usually for babies with facial capillary malformations, I'll start laser therapy pretty young, even as young as like 2 months of life, and have them do a series of treatments, maybe like 6 to 8 within the first year of life or so. And we're able to successfully do that in the outpatient setting just by kind of swaddling them and whatnot. And then, usually that's sort of our first sort of pass at things. And the thing with laser treatment, though, is that it doesn't, it's not an eraser, right? So it doesn't make it go away completely. You can get some pretty significant fading. It does take repeat courses of treatments. They may require subsequent series of treatments down the line because the tendency is for some of these to darken despite laser therapy slowly over time. So every patient is a little bit different and everyone's goals are a little bit different too, right? There are some families that say, maybe we know this is available. We know that it could lighten the birthmark, but we're just not interested in doing that at this particular point in time. And so we take that into account as well. And it really is a joint decision between us and the caretakers in terms of what the overall goals of care are, right?
And just out of curiosity, are you guys starting to do, now that the genetics piece has come down and you have, certain, angio growth markers, whatever you want to call them, we got a lot of small molecule drugs for that. Are you guys starting to use those medicines for these, or are systemic side effects looking way too high that it's just not worth it?
No, definitely. And this is another place where vascular anomalies, the field of vascular anomalies is moving at lightning pace. And we're really starting to understand the genetic basis behind a lot of these vascular malformations. And we know in most instances they're due to somatic changes in genes that are responsible for regulating how blood vessels grow and develop. And what's so cool about that is that we have really been able to repurpose targeted therapy that's, out there for cancer and things like that, because they target similar types of genetic changes in molecules. We're able to repurpose those drugs to treat patients that have really significant disease. So we're doing this a lot for patients that have PIK3CA mutations and associated vascular malformations. We're doing this for patients that have arteriovenous malformations. So genetic testing is really moving the field forward and allowing us to be very intentional when we're thinking about systemic therapy and offer patients potentially a very targeted and individualized approach.
Cool. A little peek into the future, what we might be seeing in our dermatology clinics with our patients here. So I want to first say how excited I was that we had this episode. And after now we've recorded it, I've been so happy because even though this is something that I see like literally every day in pediatric clinic, like this is like such good core stuff that we as pediatricians need to know, and those of all of us who see pediatric patients. So I want to thank you again for coming and talking to us on the show.
No, thank you guys so much for having me. This was so fun. I love talking about hemangiomas and all things related to vascular anomalies. So I'm so happy that you had me. Thank you so much.
As we wrap up, I want to ask, is there anything else you want to really, really make sure that our listening audience, anything else you haven't talked about you want us to know about?
There's two really good resources that I think every pediatrician should know about with regards to hemangiomas. So these two resources, so the first is by the AAP, and they put out a few years back now clinical practice guidelines for the management of hemangiomas. And on it has very, very nice diagrams of which hemangioma should you be worried about. And it very clearly helps you kind of categorize hemangiomas into high-risk ones and low-risk ones, and the high-risk ones are the ones that you might want to think about referring. So that is a very nice resource that I think every pediatrician should have laid eyes on or have access to. The second one is an online tool. It's called the Infantile Hemangioma Referral Score, and it's kind of the same thing, except it's sort of like a form that you fill out. And if you answer certain questions, you get a certain number of points. And basically, if you score a certain number, those are hemangiomas that you should think about referring. So if you have a hard time remembering, what about this and what about that? And is this high risk or whatnot? That's just like a quick and easy way to really triage those hemangiomas. So another resource that I think is great to have in clinic. And then the last thing is pick up the phone and call your friendly pediatric dermatologist. Or what I will say actually also is that, there's not that many of us in the country. I think there's only 400 of us. There are some states that have no pediatric dermatologists. So you have to really know your environment in terms of where you're working, right? If you don't have a pediatric dermatologist in your state, you got to figure out who's the person to refer to do propranolol. Maybe it's a general dermatologist. Maybe it's a pediatrician that just has tons of experience in terms of treating vascular anomalies. In some places, it's hematology oncology. In other places, it's cardiology or ENT, depending on the location, right? So I think that's the other thing. It's sort of know the environment that you're working in, know your network, so that way you're able to refer those patients that need this type of subspecialty care appropriately.
Awesome. Thank you so much. You wrapped up the episode perfectly, so I cannot ask for any more. Thank you again for coming on the episode. We would probably love to have you back on again because we have so many other dermatology topics. There's never ending. Every time is tons of dermatology topics, and I think you've done such a great job being able to discuss this on an audio podcast. I can't thank you enough.
Thank you, guys. This was so fun. I really appreciate the opportunity.
This has been another episode of the Cribsiders.
It's for the
kids! Get show notes and sign up for our bi-weekly Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
We're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts or contact us at thecribsiders@gmail.com. Special thanks to our producer for this episode, Dr. Clara Mao, and our wonderful social media team, which is mostly Denise Cruz on X, Blue Sky, and Instagram. I've been Sam Mazer.
I've been Clara Mao.
And this has been Chris the Chew Man Chew. Thank you and good night. Hey, Clara.
Yeah.
Knock, knock.
Who's there?
Hemangioma.
Hemangioma who?
Hemangioma going away on its own. Just give it time.
I couldn't help but laugh. All right, fair enough. You got laughs out of that.
Knock, knock.
Who's there?
Capillary.
Capillary who?
Capillary you later about that port wine stain. No. Okay, one more. Knock, knock.
Who's there?
Beta.
Beta who?
Beta believe propranolol works.
Oh.
No. Okay.
That was a little.
I'm done.
Good try.
The first one was good because it was spontaneous. Didn't expect it.
We're cutting it. We're going. No AI poems today. See you guys. Bye.